Hi, my name is Dr. Sabrina Gerkowicz, and I'm one of the reproductive endocrinologists here at IVFMD. And today I wanted to spend a little bit of time to talk to you about something called endometriosis. Primarily, we're going to give an overview today on what it is, how do we diagnose it, how might it affect one's ability to get pregnant or respond to fertility treatment, and then how might it affect pregnancy, as well as what are the possible treatments for it. So it's a lot to talk about. We're only going to be able to get into just a brief introductory phase of each of those topics, but certainly if this is something that pertains to you or something that you would like more information on, it's a really important thing to talk to your doctor about. So first and foremost, we're going to talk about what it is. So endometriosis is typically defined as cells that are like the cells found on the inside of the uterus, or endometrial cells that are found outside of the uterus, typically in the pelvis, on the ovaries, fallopian tubes, uterus, or on the inside of the pelvic cavity. These implants, like they're called, endometriotic implants, can also be found all over the body. So everybody's presentation is really different, and distribution of disease. So how might they get there? This is still a very highly studied topic because we really don't have a way to exactly pinpoint that cause. However, there are a lot of theories that are believed to explain how these implants get outside of the uterus. And typically the most common thought is something called Samsons' theory of retrograde menstruation, where some of those cells during one's menstrual cycle do backflow essentially through the fallopian tubes and into the pelvic cavity. And at that point, they can adhere or stick to any one of those places like we mentioned. So given that those are cells like endometrial cells, they're responsive to the hormones that we have that fluctuate during our menstrual cycles. So typically estrogen and progesterone, all of those hormones affect those cells cyclically, just like your endometrial lining cells would be affected during the different points of menstrual cycles. So that is typically where the medical management is targeted towards trying to calm those responses to those hormones. It can naturally cause some disease, some pain where those pieces of the endometriosis implants are, but that will typically refer throughout the pelvis. So people might have really painful menstrual cramps or pelvic pain. And in addition, where this might then impact one's ability to get pregnant are through, again, a couple mechanisms. Again, it's really hard to pinpoint or identify the exact cause in each person. However, there are some theories that suggest a couple different mechanisms. Increased inflammation is thought to be involved. So these endometriotic implants can cause local inflammation to those areas. The body's reaction to inflammation would be to cause some scarring or scar tissue. So the scar tissue development can impair how those parts of the body function. So if the fallopian tubes are involved, it might impair their ability to move or contract, as it is a muscle and it is supposed to do that to help throughout ovulation. It also might not be able to capture the oocyte from the ovary once it's been ovulated. So its function can be affected in a couple different ways. The inflammation can also affect the local environment, and that can cause some quality compromise to the environment that the eggs are developing in, so affecting the ovary, as well as the actual quality of the egg itself. So a couple different ways in that regard. So inflammation is one of them, scarring is another, quality is another. And a lot of those tend to be the ideas that hold the highest regard in our specialty, although again, it's very hard to know, and it seems as if there are many different aspects of the disease that can translate into impairing fertility. In addition, There can be some other effects in terms of the embryo quality. So if we're concerned about the oocyte quality, it's possible that that will also translate into poorer embryo quality once the sperm and egg are together and fertilized. So those are some of the preliminary reasons that we suspect it might impair one's fertility. We also know that it's hard to get this data in the general population, but typically couples, their month-to-month chance of getting pregnant, if one is having regular cycles, ovulating, sperm counts are normal, there's no uterine or tubal factors, can be up to 20 to 25% when one is in their 20s. As one ages and gets into their 30s, and most certainly mid-30s, later 30s, and 40s, that percentage per month does continue to decrease. But some studies looking into couples who face endometriosis have found that those month-to-month rates are lower. So even if all factors are optimized, that chance month-to-month can be about 5 to 10% lower. Again, depending on a lot of different factors, and these percentages cannot be held as absolute. But it does give some idea into there might be some of these mechanisms making it harder to conceive on one's own when endometriosis is involved. So with that, that will lead into when you do see a fertility specialist, or if you do see one, in the treatment options that we can discuss or recommend, there's always a small chance that with timed intercourse, intrauterine inseminations, or IVF, even again, if everything is optimized, there still might be a slightly lower chance of pregnancy or success. And this has been supported through some studies, especially looking into IVF chance of pregnancy. So with all of that, is there any reason to either treat it or do something about it in hopes to improve chances of conceiving or improve response to fertility treatments? The literature on that tends to be a little bit mixed. Surgical management used to be recommended. Surgery is the only clinical way to 100% diagnose endometriosis, classically speaking, where a laparoscopy is done, the pelvis is examined, and endometriotic implants are identified, sampled, and then sent to pathology, so we have histological confirmation that that is in fact endometriosis. But studies have shown that putting everybody through a diagnostic laparoscopy has not shown to lead to a large enough benefit to outweigh the risks of having a diagnostic laparoscopy in all of these women, especially if they're asymptomatic. Given the improvement in our fertility treatments, that's another argument against doing surgery on every patient, because our technology has gotten better, so we can still offer really good pregnancy treatments or fertility treatments, and in lieu of having to do surgery as well. Where surgery is definitely warranted is if there is significant pelvic pain, or if there's significant adhesive disease or other issues that do affect one's month-to-month quality of life. If there is a large endometrioma or an endometriosis caused cyst on the ovary, it tends to be filled with old blood. Sometimes if that has been found to be quite large, then that is worth a discussion of possible cyst removal as opposed to drainage, because the drainage is not as effective and it can be more likely to return or to come back. But that is a really individualized discussion based on your entire workup and all the other parameters as to see whether that makes sense, or continuing with fertility treatments and working around that would be a better option for you. So surgery is a really individualized decision, and it's a very individualized option based on your circumstance, but something to be talked about or discussed with your doctor once all of your workup parameters have been evaluated and you have a big picture of what your options are. Medical treatment tends to prevent pregnancy as it is related towards the hormones. So medical management of endometriosis is a really great option for people, but in times when they're not actively trying to conceive. So that discussion, again, there are various options that vary in their effectiveness or efficacy, but that is something that would not really work well in conjunction with trying to get pregnant or with active fertility treatments. So overall, there's a lot of different ways that endometriosis can affect one's ability to conceive and one's chance of getting pregnant, especially once fertility treatments have been started. So that's why, especially if you have a history of endometriosis, it's a good idea to talk to your OBGYN or seek a fertility specialist evaluation when you know that you are interested or wanting to try to start your family. Because there are certain factors that we might identify on a more detailed workup that may sway your decision process one way or another, or can help arm you with information to make more effective decisions earlier rather than later, which is always really important. In terms of the egg quality, certainly optimizing your health is always a great important option regardless of what you're doing, but this might be something again that endometriosis, we don't really have a perfect way of specifically targeting how it affects egg quality. So having earlier consultations where we know that with age factors, this might again lead us to have some better options and better pregnancy chances. So this is a very complicated topic and not one that we can really completely discuss in just 10 to 15 minutes, but hopefully it does provide a little bit of an overview, and it does explain a little bit more on why we think about it so much when it does involve fertility and trying to get pregnant. There's a lot of research that's actively underway, and certainly as our understanding and knowledge of our genetics and how our environment affects our genetics, all of these things are continuing to evolve. So hopefully with time we'll have better ways of treating it, better ways of getting around it to help one get pregnant. So all of these things are continuing to evolve. So with that, I hope it was helpful. Please, if you have any questions, be sure to reach out to us, and we're happy to help. We're happy to answer these questions. There's so much more detail to go into, so I do acknowledge that this is very from a superficial level, if you will, but again, I hope it does start the conversation, and we hope that if we can be of any help to you, we're happy to. So thank you so much, and reach out to us with any questions.